20 years ago, there was still a huge amount of prejudice against people living in larger bodies. It was this attitude of these children shouldn't be in a hospital, they should be eating less, is it their parents' fault? You know, when you respect human beings or when you love children, you can't really tolerate that.
How does obesity affect children's bones and how does it affect their movement?
If we develop obesity at a young age,
There is a sense of shame if you're a parent and your child is living with obesity.
parents are worried that they're going to come in and be judged, and rightly, a lot of parents don't want to bring their child into that situation. So it's really important for us to explain that's not what it is.
That a lot of children that are living with obesity, they would live in areas of food poverty. Sometimes there's no access to a kitchen or a cooker or even a kitchen table.
So it's very hard to understand what that means if you haven't experienced it. We have a problem that we need to address.
Grace, it is an absolute pleasure to have you on the show. I'm really glad to be having this conversation with you. So let's just start from the start. What is it exactly that you do?
Okay, so I work in the School of Physiotherapy in RCSI, and I also work in Children's Health Ireland at Temple Street, and then also we run clinics in Connolly. So I'm a physiotherapist by training, and then I kind of got an interest in childhood obesity from a perspective of their bone health. So when I started working, children seemed to be injuring themselves more or taking longer time to heal. So I started on a little bit of a research journey looking at the development of the lower limb in children with obesity and how carrying extra weight through the first decade of your life might impact how your bones develop or how your muscles develop or how you walk, how strong you are, or if you have balance difficulties. So that was kind of my first introduction to the area. And I was really lucky that I was able to get funding for a master's in Trinity under the Hussey Gormley Fellowship. I was really lucky to do that. And then I started working in Temple Street, as it was known then, Temple Street Children's University Hospital. This is back in 20 years ago. And then I kind of carried on doing a bit of studying on the side. So I was working clinically full-time and then started out thinking about maybe I should do a PhD because we need to really think about what we're doing in practice and make sure we're doing no harm and trying to do things in an evidence-based way. Because back then, 20 years ago, there was still a huge amount of prejudice against people living in larger bodies, and often it was the child that was being blamed for their body. So it just didn't sit right. It wasn't right. Didn't seem very evidence-based, and our health system was completely unprepared to care for these children or do anything about it. And there was a lot of stigma, which I know you've addressed previously as well. But what that looks like in reality then is not only, our children stigmatised by the media, by strangers on the street, by their own families sometimes, but then healthcare. So when they try to access healthcare or their parents bring them to access healthcare, they can't access care, or the care they're offered is kind of peppered with prejudice and anti-weight bias, or back then it was this attitude of these children shouldn't be in a hospital, they should be eating less, this is their parents' fault.
I honestly feel emotional when you're talking like that. I really do.
I know it is. It's terrible. Oh. So when you when you respect human beings, or I'll use the word love, when you love children, you can't really tolerate that. So I suppose that really was the motivation for me to kind of think, oh God, what are we going to do and how should we do it? So I was really lucky. I got a Fulbright fellowship to go to the States and work with like a really fantastic team there led by Professor Sonia Caprio, who is really a world expert on trying to understand how obesity maybe contributes to the early development of type 2 diabetes. So we used to never see type 2 diabetes in people under maybe 60, just even 20 years ago. And then it started to emerge that we started seeing children much younger developing diabetes much earlier, type 2 diabetes. So it was wonderful to work with their team. And Sonia had been doing like a long series of studies looking at the pathophysiology of type 2 diabetes in children with obesity, but also her colleague, Dr. Mary Savoy, had been really at the forefront of treatment in terms of lifestyle approaches and rehabilitation for these children. So it was wonderful to work there. I was very lucky in a sense that I was part of this world-class team delivering care that was kind of the best type of care you could get worldwide. And then I was really lucky that I was living in an area that was very deprived while I was over there. So on the one hand, I was seeing how deprivation and poverty can exacerbate things like obesity and chronic disease, while also living in a neighbourhood that had a lot of challenges around deprivation. So what that meant, though, practically was I would have to get on a subway and go maybe 20 blocks to buy vegetables. So that was a really first-hand experience for me of when you're living in an environment that does not promote health or nurture or nutrition, healthy nutrition for a growing child, unless you have the capacity and then the opportunity in terms of financial capability to get on a train and go to a supermarket and buy vegetables, that's not going to happen in these neighbourhoods. So that was a really interesting experience. And while I was there, this was 2009, 2010, social media or the smartphone was just coming out. And it kind of got me thinking about digital care. And I suppose on the one hand, I was worried about the ethics of mass media and how it can be used to influence in a negative way in terms of health. But I was now in this wonderful team in a situation where they had the best care available, and yet trying to deliver to the numbers of children that needed care was a problem. The health insurance system over there was very complicated. It meant that there wasn't coverage for all children who needed this type of care. So that kind of got me thinking a lot about our health services and how they're designed and our health system, universal care, children's rights in terms of accessing care. So when I came back to Ireland, I thought maybe I should do a PhD and look at it from the aspect of digital care. So could we do anything with digital care to try and help meet the demand? And at the time, I suppose there was kind of a lot of reluctance, I suppose, from a scientific and healthcare point of view, because this was all very, very new in 2010. And I remember asking one of the teenagers I was working with, like, what do you think about us trying to design something that teenagers could use? What do you think about that? Like, does that make sense, or am I off my trolley? And he was like, well, if a child is if someone's looking down, there's no point talking to them there. You have to talk to them here. So I said, well, okay, that does make sense. And even though I'm uncomfortable about doing this, because ethically I have challenges around it, I thought, well, maybe it makes sense to have somebody who has experience in this area doing it rather than someone from industry or someone from the tech industry or who doesn't really understand the nuance of treatment. Mm-hmm. So then I started a PhD through UCC, Department of Public Health and Epidemiology, with Professor Ivan Perry. And that was funded by the HRB. So for that programme of research, I developed a telemedical system for adolescents, and then we tested it in a clinical trial, and then we looked at what we were doing in person as well. And that kind of led to, a whole series of studies around telemedicine and how do we do care and how do we transport what we do in person online, and how do you actually communicate with people genuinely and authentically through technology.
So not as a person talking to them, more like an app style?
Through the app, yeah, okay. Through the app. And what elements of in-person care do you need, and could you just swap it all over to app? And so it was a really interesting experience. And then as a physio, I suppose, I'm always wearing the hat of rehabilitation and function. So it doesn't matter to physiotherapists what someone's condition is or at what point in their journey or where they are in their health. Our job is to enhance quality of life and support movement and support health. So it's interesting to have come into the obesity field with wearing that hat, because prior to, I suppose, in that first kind of 20 years, the first, maybe 30 years to 20 years ago, 25 years ago, it was much more a field of sports science. So you just need to burn the calories. Mm-hmm. Whereas coming at this from a rehabilitation angle was much more about, well, why do kids with obesity find it harder to move? And back then it was like, well, they're lazy, or they're just not interested, or their parents don't care. And so none of that is true. And when you start to actually, use evidence to understand what's going on from a movement point of view, you start to see, well, there's actually barriers to movement. These kids have limitations and impairments. And like any other child with any other condition, we have to screen them and assess them properly, and then figure out a plan to help them get the best out of their life. And that takes loads of different forms. And that's why kind of treatment requires a multidisciplinary approach. So you need to have your expert in dietetics, you need to have your registered dietitian, your registered physiotherapist, a psychologist, social worker, particularly when you're working with families, your paediatrician, maybe an endocrinologist. So, but this whole field has really evolved over time. So, I'm really proud that in Ireland, even though we, for many years, only had one service in the country, our service is really at the forefront, I would say, internationally, in terms of the multidisciplinarity of it and thinking about these children and what they needed. So often, a lot of healthcare and medicine comes with from a very biomedical approach, and through the lens of, I suppose, medicine and surgery, and the treatment is a surgery or the treatment is a medicine, and that's how you fix diseases. But when you have a biopsychosocial approach, and which is particularly important for childhood illness and disease, you're thinking about the child like like an onion. So the child or the baby is in the centre of that onion, and then there's all of these layers: the layer of the family, the layer of the school, the layer of the community, the layer of the kind of politics that this child is growing up in, the layer of cultural influence, and all of these layers have an impact on a child's development. So that necessitates, you need to have this kind of looking at it from, well, if a child isn't moving, why? I'm trying to understand. If a child is seeking food a lot, why? And trying to understand the root of that. And
is there an answer to that? If the child is seeking food a lot, why? Or is it different for every child?
It is different for every child. And it would be much easier if things were just able to be categorised. Now, we do start to see in the research that we're trying to move towards this idea of phenotypes. So a phenotype is where, you might all have the same condition like asthma, but how it affects one person will be very different to the other, and what their symptoms are, what their signs are. And in big chronic diseases like cancer or obesity or heart disease, you see different subcategories of these conditions. So we are moving, thankfully, away from this idea that there's one obesity and understanding that there's lots of different forms of obesity.
And can I just ask you one thing about the movement thing? Because you said that at the start, and how it can affect their bones. Firstly, how does obesity affect children's bones, and how does it affect their movement?
So depending on when a child develops obesity, so we have to understand, so with kids, when they're developing and growing, so we have cells in our bodies, and as we grow, our cells get bigger and we get more cells, and this is how we grow. But not only do we grow in terms of cell number and size, the ability of those cells to talk to each other in the body allows us to mature, so to develop. And they're very different things, and it's something that in adult healthcare and adult medicine, adult science, we don't have to deal with, and we don't think about it. And adults generally think through the lens of an adult body. And this is why paediatrics is completely different. Children's physiology is different. You're always thinking about a child at a different developmental stage, what they should be able to do at that point in their life. So, what a 2-month-old does compared to a 2-year-old, compared to a 10-year-old, compared to a 16-year-old is completely different. Their body's maturing as they age. If they're exposed to, things that allow them to develop. So, one thing that I always keep in my mind, and I don't know why it's in my mind, it must have been because it was very shocking at the time. I remember being probably 9 or 10, and Romania Ceausescu had just been overthrown. And then at the time there was all of these children in orphanages. So this must have been on our Irish news, and it really impacted me at the time. And what we know about, so if you have children, let's say, who do not get exposure to stimulation, so if they're left in a cot, if they're left in a room and they don't have social stimulation or physical stimulation or emotional stimulation, they do not develop in the same way as a child who gets exposed to all of that. And that's really important when we're thinking about the environment that we have children growing up in, because the importance of a healthy environment is paramount for a child to develop to their optimal ability, I suppose, for them to thrive. So it's not just about calories or, feeding a child. It's about nourishing a child and that they can develop into their full potential.
Sure, even there's studies done on babies in NICU, in incubators, and if their mum or dad or anyone sits and talks to them or touches them, they thrive so much better than if they're left there and fed, of course, and kept warm. But there's a difference. So
absolutely, yeah. So
sorry to throw you there.
No, I'm trying to remember what the question was.
The question was how does obesity affect their bones and their movement?
Yeah, so this is really important in terms of all of those inputs. So bone requires movement, so we need muscle pulling on the bone in order for it to change shape as a child grows. So it's in adults we think about bone mineral content and we think of bone mineral density, and that's a very kind of two-dimensional way of thinking about bone. But in in adults as well, but in developing children, so you have your 18-month-old who starts to stand, and as they stand, they're getting weight through their legs, and then they develop a kind of a wide base of support. Their feet go out as they're trying to stay upright, and they'll do everything they can do to stay upright.
Oh, they're so cute.
They
when
are
they're doing that.
And then they'll be. As they're growing, then what actually has happened is the bones are turning. So they're becoming really amazing pieces of architecture in order to actually keep us upright. So in order for that turning to happen, we need activity. So we need ground reaction forces through the bone, and we need the muscles pulling on the bone. And if children don't get that, as well as their vitamin D and their calcium and protein, you get bones that are weak or bones that aren't actually architecturally optimal. So they're not turning. They're if you think of a building and what in engineering, what's a really steady or solid piece of structural part of a building, it's cylinders. So different forms are more architecturally sound, and in our body we have this amazing, incredible tissue called bone that is able to give us optimal function by turning and reacting. So if we develop obesity at a young age, particularly if it's very young, so if we have maybe obesity from 6 months or 1 year. Now, these are very rare forms of obesity that develop before age 5. So early onset obesity, usually we refer to as kind of more genetic forms of obesity. So these might be children who have very rare genetic forms or maybe syndromes. But even if it's not those types of obesity, if it's more, let's say your 2-year-old who maybe is still having a lot of feeding at night, and maybe getting, the nutrition might be suboptimal, so they mightn't have the best nutrition or the best quality nutrition, and they might be gaining weight because of that, or there might be something going on with their appetite. But for whatever reason, which we can go into later, but for whatever reason, if they're gaining more fat tissue at that age, 2 things are happening. They're having more mechanical force through the bones, which can often affect the inside of the knee, and then it'll cause more knock knees so that the feet go out. There's a wider base of support, and most people have seen this in their own family or neighbours. Their knees are banging off each other when they're walking, but there's a huge range of what's acceptable for that. But for children with obesity, this can happen to a kind of a greater degree, and it can impact how they walk. So when it's very severe, it might mean that child can't run. They physically cannot run because their anatomy will not allow them to. And in some severe forms, you may need surgery for that from an orthopaedic surgeon. So on the one hand, you're getting this mechanical impact, but then also because fat tissue is so metabolically active, you're getting a lot of hormonal and kind of inflammatory markers moving around the body, and that can actually affect the bone as well.
So it's literally like a vicious cycle almost when it happens like that.
Especially at this time of growth.
Yeah.
So your bones are really changing and forming until around, till puberty, but particularly till around 7 years. So if a child develops obesity before 7, often the signs of that will be a musculoskeletal, so the bones and muscles. Or the child, let's say the 5 or 6 year old might be wanting to go in a buggy, they might be wanting to be lifted, they might be getting pain, they might be very tired, their muscles actually are more tired because they're not adapted to it.
Those symptoms.
Yeah, they can, and often sometimes that's kind of like, oh, you're just lazy, and it's not. That's the whole point. That's why it's so important to kind of assess these kids properly and understand why most children want to move. It's natural. They want to move, and they move in a very spontaneous way.
Absolutely,
it's much more episodic. You know, they're not going for an hour walk like adults, but they want to jump and turn and dance and jump up and lie down on the floor, and they're the things they want to do. That's how their body is meant to move. So it can be harder for these kids to move because of their anatomy.
And so it isn't just that they're carrying the weight and that they're slower as a result. It's actually there is change going on within their bodies that makes it difficult.
Yeah, exactly. So they might get more knee pain or foot pain or back pain. Breathing might be more difficult, so it's harder to move around. So that can be something that parents, it's a light bulb moment for them when they understand that actually these children, it's harder for them to move. They spend more energy moving than their counterparts who are lean, because their body is using up a lot more energy to actually move the body. And then, so I suppose the key thing is that your body will be affected through growth if you're carrying extra weight. Now, it depends. There's a huge range of what's okay, and children are growing all the time. You know, on average, children will grow or in terms of weight, they'll put between 2 and 4 kilos on every year as they're growing. And then you'll have periods where you'll gain a lot more. You'll have a growth spurt. You might have periods where you're not gaining much weight, but you're gaining height. So often when we're talking to families, we'll talk about growth. We're not talking about weight. We don't ever really talk about weight at all to children. We talk about growth, and we use kind of the idea of, you know, children are getting tall, they're growing in height and they're growing in weight. And sometimes the height is growing faster than the weight, and sometimes the weight is growing faster than the height. So what we want to find out is that impacting the child in any way? And then if it is, can we do anything to support them to make sure that they reach their height potential? And that's where nutrition is so important. So this idea of dieting
Can I just ask you there just one thing? Sorry. If a child is obese, can that stunt their growth as well?
If they're malnourished, yes.
Okay, yeah.
So when children have obesity, and we usually say living with obesity or with obesity, because there's this long kind of history of pejorative language for people in larger bodies.
And I actually said that to you before the podcast.
You
I said,
did. And I could have let it slide too, but
so I'm glad that
we kind of always have to.
And I'm going to leave this in to the pod.
Yeah.
It's really important.
And it's not a bad thing.
No, but it's really important. It's living with obesity, living in a bigger body.
Yeah, because it actually changes how we think about it. The minute we use the language in a different way, it makes us think less about the person being to blame for it.
Yeah.
So, yeah, I think, you know, it's important that people understand that the child is growing, and that we want to support growth and health, no matter what the condition is. But that issue of potentially, just because there may be calories, it doesn't mean there's nourishment. And so you can have children who have obesity and who are malnourished. And you will often have children in general who won't be reaching their height potential if they're not getting the right nutrients, because we need our bones to grow and we need our muscles to grow. So often that's why it's so important to have a balanced nutrition. So you'll have carbohydrates and proteins and fibre and vitamins and minerals and fats. And really important that people understand, particularly for children as well, that fat is important in their as part of their nutrition for their nervous system and their organs and keeping them warm. So yeah, the bones can be affected, but then also your breathing. So if you're a little child and you're carrying a lot of extra fat tissue, particularly around your chest or your neck, that can really impact breathing. So it may mean that at night time there might be a lot of snoring, there could be sleep apnea. So you literally think if there's fat tissue around the neck, the child's windpipe, most kind of up until the age of 7 are bones. There's a lot more kind of cartilage hasn't fully formed yet in children, so it can be quite spongy and the airway can be quite floppy. So if you're carrying extra weight around the neck at that age, it can really impact breathing. You might have sleep apnea. So parents might be a little bit concerned at night if they hear their child gasping, or if they stop breathing for a few minutes and they're kind of worried, like what? And they'd be up checking them. So if that's happening, then parents should be definitely bringing the child to their GP, and then they'll probably be referred to a paediatrician or maybe a respiratory consultant to check if there's respiratory issues, and then they may be referred to ENT to see if, well, is it that the adenoids or the tonsils need to come out? Is there just too much adenoid and tonsil tissue for the child's airway? It's causing them to snore or to have sleep apnea, or is it actually just the function of excess fat tissue? So,
and how long does this process take to get referred in to see someone like you then?
So it depends on the situation, and it depends on if there's complications. So often if a child is kind of in a bigger body compared to the children their age or to siblings at that same age, I mean, the most important thing is to think about, well, is it affecting their health? So just because they look a different shape or size, it doesn't mean that they're unhealthy. It doesn't mean that you even have to start the discussion with the child at all. It's about if there's complications. So you could have a 3-year-old child coming home and saying, no one wants to play with me. Or you might have a 4-year-old child not able to keep up in playgroup or wanting to be in the buggy a lot. And you're kind of trying to figure out, well, why is that? Do they need to go to see their GP? So under 8s will have free GP care. So important to go to the GP first. They'll do growth monitoring. They'll also do a health screening, check their heart and lungs. And then they'll make a decision whether the child may need to be referred to primary care services, so to a dietitian or to a physio or a psychologist maybe, or whether they think they should be referred to a general paediatrician first in one of their local hospitals, and thereafter, if the general paediatrician sees them, they may decide, well, we need them to see an endocrinologist, or we need to refer them to a specialist obesity service. Or sometimes the GP straight away will refer to a specialist obesity service if they meet the criteria for acceptance. So currently the one specialist obesity service for tertiary care, so hospital level care, is in CHI, Children's Health Ireland. And the child needs to have a body mass index over the 99.6th centile. I'll talk about that in a second. And 2 complications. So either that they have metabolic problems, so maybe they've high insulin or they've high glucose blood sugar. They may have signs of fatty liver disease, metabolic fatty liver disease.
And what's the signs of that?
So it may be tired. So it's one of those kind of conditions where there's a whole cluster of things that could menopause, be anything. Yeah. So pain in the abdomen, tiredness, fatigue. And they're mostly the 2 common symptoms that come with non-alcoholic fatty liver disease, but that is a kind of a silent condition. So often it might be that someone might go to their GP, they might decide, well, look, we're going to do bloods, and then on their liver enzymes they'll see that there might be signs. Then they might say, okay, well, let's do an ultrasound, let's check the liver, and you might find kind of high levels of fat in the liver. And but the good news is that if that's there, it's actually pretty easily to treat that and to turn that round with lifestyle approaches, which is great. So it's not, the end of the world, but it's important to not let it go and not let it be treated or assessed properly. So respiratory conditions maybe, so maybe a worry about sleep apnea or a lot of breathlessness, that would be another complication. Orthopedic problems or mental health aspects as well. Now that might be mental health complications in terms of having kind of negative body image, so the child disliking their body or speaking about that, not wanting to be in the body they're in. It might be related to low self-esteem, might be related to having, teasing and bullying. So there's a kind of a multitude of things that can present for any child living with obesity. So if there's 2 complications and then large body size measured using growth charts, then they could be referred to the specialist service in CHI. If people live in Community Health Area 5 or Community Health Area 7, so that's kind of Tala and then Wexford region, there's also 2 community-based teams that have been funded under the model of care for obesity. They're getting established at the moment. So parents who have concerns in those areas could get their GP to refer to those services. Otherwise, around the country, we're really limited. So this is where we need to respond properly as a health service. So we saw a really amazing response to COVID internationally from a scientific point of view, from a healthcare point of view. Everybody rode together in terms of how do we treat this new condition, how do we set up services, how do we deliver care, and it was done. We actually managed to do that, which was incredible. And at the time I remember thinking, that's amazing. So now we can do, now we have to do this for obesity, we have to do it for disability, we have to do it for all these things that we're not doing it for. So we do need the government, whoever's in power, to make sure that they fund the model of care for obesity and the model of care for paediatrics.
And what are the limitations? Is it money? Is it professionals like yourself and others in the multidisciplinary team? Is it resources? Is it research? Or is it everything? Are we lacking?
A bit of everything. I mean, I think that we do have a whole group of health professionals who are in the health system that want to do more for this area, and through our research we know that. So there's a body of people who are just willing to do something, but they need resourcing in terms of equipment. They need to be able to have height measures and blood pressure cuffs that are suitable for children in their practices. The GPs need to be reimbursed. The practice nurses need to be reimbursed to be able to address this in a meaningful way. So it's not about just monitoring growth, it's actually offering the brief intervention or the treatment that's needed. And then the primary care teams need to be funded, so there aren't staff. Even if there is money for staff, sometimes there's money, but we can't recruit because there was an embargo for, let's say, 10 months of last year. Then the embargo lifted, and then you still couldn't recruit, and then jobs were kind of disappeared. So there are issues with recruitment, and then there's a huge issue around training. So most health professionals have zero training in the area of obesity because it is a brand new condition. So our curricula at undergraduate level aren't up to date. So we've been doing projects trying to address that. So we've been working in RCSI and in University of Limerick to get, and we want all the other colleges to do the same thing, to get mandatory training around obesity in all their health professional courses, evidence-based treatment and training. It can't be the old, this is just a very linear problem.
Yeah.
So we need better training, and then we've been really lucky that the Department of Health and the HSE have funded us to develop an free online course for health professionals. So it's up to 5 hours of CPD for any health professional to really get some high quality education online.
Is that currently available?
Yeah, so childhoodobesity.ie, so www.childhoodobesity.ie. There's 5 modules. It'll take you through kind of an introductory module first, and then nutrition, physical activity, practical measurements, working with adolescents, psychosocial aspects, endocrinology, orthopedics, general medicine. So any health professional listening, please do that. Or if you're a parent and you're going to see your GP, please encourage your GP to do it.
And is there anything similar for parents?
We have to develop that next.
Okay.
Yeah. So in the hospital in CHI, we've been delivering care for 20 years, and we have lots of resources. Some of them are available on the Childhood Obesity website under the health, under the parents resource section. But we want to update our health professional course and do a version for parents too, because I think there's a huge need. There's so much misinformation out there. It's really hard to get high, kind of decent, well, no, that's wrong. the HSE website has really good information. Safe Food have really good information, and the Department of Health have some really good information. So it is there, but you kind of have to go looking for it. So I think it would be useful to have a one-stop shop for all of this stuff, so that parents or health professionals can access everything really easily in different formats as well.
And the thing, the parent link is so important, because we spoke earlier, and I'd just like you to go through, say, a typical consultation that you may have with a family, and how that family is walked through and guided through their child living with obesity. Because there is a sense of shame if you're a parent and your child is living with obesity. I've heard it, I've seen it. It's come into the question box when I said that I had someone like you on. Parents don't know where to turn to. I had another doctor on, about a year ago, and she said that they're in the obesity clinic. Sometimes patients don't turn up because of, and it comes back to the shame around the fact that they're bringing their child in and their child is living with obesity. So how do we manage all that, or what do you say to those parents? How do you deal with parents in your consultation when you first see them? Like, how is it all dealt with? Yeah,
well, we deal with it from when the referral is triggered. So, like, this is the really important point about, I suppose, a team and a service that functions properly. So your administrator, and the administrators get an awful lot of flack when we're talking about costs in the HSE, and it's the
management,
admin,
too much management.
Admin are absolutely essential. They are actually so crucial to every team, and if your admin doesn't know what what your service does, or they don't feel a member of the team, that's a problem. So from the very first time we get a referral in, after we triage that referral, our admin will send a letter to let the family know that they've been referred, which sometimes they don't even know that they've been referred, because maybe someone didn't want to have the discussion with them, or maybe they had the discussion, they think that the parent understood what was being said, but they didn't. So that initial bit is important, that letter. And the next bit then is when they are added to our waiting list. So they'll be triaged, added to our waiting list, and then they will get an appointment. We need to send out information about what that appointment is, what to expect. And this is really important, because parents are worried that they're going to come in and be judged and be put on a diet, and the child will be made feel crap. And rightly, a lot of parents don't want to bring their child into that situation. So it's really important for us to explain that's not what it is. So we focus on growth, we focus on positivity, we want to understand your child and what they love, what they like to do in their spare time, how do we support them to do that. We want to just check if there's anything in terms of health complications that we can help manage or help prevent progression of. So when the patient comes in then, we also have to think before they actually come on the day, do we need translator services? Does the child have maybe another condition like autism or ADHD? Do we need to think about where they come in terms of the day, in terms of the time, what would be better for the child?
God, it's so child-centred.
Well, we are very child-centred, but there's a huge cost to that in terms of administrative time. But it's really important. So I think that it all starts with that. You have to plan your service. Now, we're in a building in Temple Street that's, it was an old house. So one of the parts of Temple Street was Parnell's family home. So these are old buildings that weren't built, designed as hospitals. So we have small spaces. That becomes very problematic when you have families who are in bigger bodies, because already it's an uncomfortable space. So access to clinical space and appropriate clinical space is important. When the family comes, the first thing we'll ask is, do you know why you're here? And I would say it's improved over time, but still probably 40% of families say no, they don't know why they're there. And then that means that you're setting up your conversation in a very different way to a family who the parent might say, yes, we know why you're here, or we went to the GP and the GP was concerned about their weight or their growth, or sometimes it'll be the child or the teenager that will say, I know why I'm here, I need to lose weight. And then we'll have the conversation, well, maybe you don't need to lose weight, actually. And they're like, what? And we're like, well, maybe you don't, because often we just need to maintain weight through growth. And that's really important.
Oh God, that's a real
I
positive
know.
spin on it, isn't it?
Yeah, so I mean, you're trying to, and it's not that you're trying to be kind of fuzzy wuzzy for the sake of the child liking you. It's not about that. It's actually about being neutral, but using the evidence base to explain. So often it'll be a case of, again, that kind of analogy of, well, you went to see this doctor and they may have said that they were concerned about your growth. So maybe your height was growing slower than your weight, and so they referred you to our clinic. And my job is to ask you loads of questions today and get an understanding of whether your life, what's your life like in school, at home, what's your health like, and is there anything we can help you with today? You might decide you don't want to come back, and that's okay. 9 times out of 10, they will decide to come back, but you're always given that option, because you don't want, particularly adolescents, there's no point in making them feel like they have no choice. Yeah. So then we'll say, we're going to go through all of these really annoying questions. There's lots of them. Most of them you'll be able to answer yourself. Some of them your parent will answer because you won't remember, because they're about when you were a baby. And I usually say, and I'm going to write little tiny stars on the things I want to come back to, and maybe think about doing something about them. So it might be when we get to the section, particularly around screen time or sleep, often I'll be like, do you mind if I put a little star on that one? And they already know, particularly the teenagers, like if they're using screens for 6-7 hours a day, they know. And not all children are, but some children are. So then you're explaining that the assessment bit. So we're going to be doing blood pressure, we're going to do growth, and then we're also going to get you back to do a physical exercise test in physiotherapy. We're going to look at your heart health and your lung health, how you move, how strong you are, and if there's...
Do you do ECGs on these? On everyone as well?
No, we don't currently. We do a submaximal exercise test for most children on a treadmill. Some will do a bike test and some will do a functional walking test. So depending on their age, if there's concerns about their heart health, they'll be referred to cardiology and they'll have an ECG. But most of all, generally we're managing it ourselves without the ECG. So then, you know, you're bringing the child through all of these aspects of their life. And I think it's very, I don't know from, because I'm not a child now, but it is interesting to see how they react when you're actually interested in all of these things. Because I think they come and they think you're going to just talk about their weight and their body and kind of objectify them in a way. But instead, our whole service is trying to understand about everything about them. So they'll then see our dietitian, who'll go through obviously what their nutrition is, their intake, but also their variety of foods, any sensory concerns around chewing or swallowing, or any restricted eating, the pattern of their eating, the timing of their eating. Are they skipping? Many children are skipping breakfast and skipping little break and only eating at lunch, or some of the kids don't want to eat in front of other children in school, so they're fasting the whole day.
I've heard of that. They don't like eating in front of other people.
Yeah, so depending on what the school environment is like, that's really concerning, you know, because you really, so part of our work then is to try and encourage, healthy eating pattern and understanding that we kind of building up that confidence in themselves as well. And everybody is different, of course. So this is coming out kind of like it's a very negative situation. For some children will have multiple complications and life is really difficult. Some will only have 1 or 2, and everybody's different. So they may have more cardiometabolic stuff. So it might be that they have blood pressure problems, or their bloods are off, might have high cholesterol, so high levels of fat droplets in their blood. They may have difficulty with their liver, with fat accumulating in the liver. Or some of them won't have any of that stuff, but they'll have breathing difficulties or movement difficulties. And then they'll see our psychologist, and the psychologist will be thinking about, okay, what do they like? How do they get joy in their life? How's their education? What's school like? Have they had any teasing or bullying? How do they feel about themselves? How do they think about their body?
And are the children very open in these conversations, or does it take them a little bit of time? It depends
on the age, and some of these questions you wouldn't ask to everybody, and it depends on if there's enough time in the appointment. It depends on what the relationship of the child and the parent is. It depends on the communication capacity of the child. So some children will have communication issues themselves. Some children may have a lot of anxiety, but generally it's just incredible when you can have these open discussions with children and teenagers and they know themselves. They're able to speak about it. Some will find it harder. Sometimes there'll be tears, and that's a positive thing mostly, because often no one's really asked them these things, and it might be the first time they've actually spoken about this thing that they've been holding on to for a long time, that they've been made feel shameful about, you know. So it is really important. You're trying to judge what is the least amount of information you can get without causing harm, but also having an honest discussion and having the child understand that you actually really care about them and that you're authentic and that you're going to do your very best to bring all of our skill sets together to see how can we help them. So usually people will speak, and for the teenagers maybe who don't want to speak or articulate, they'll still stay in the room. So, you know, when we're thinking about what is success in this area, the fact that the child or the teenager stays in the room is pretty good. The fact that they, over time, will be able to articulate themselves is really good, that they're able to partake in their treatment themselves and be part of it. Sometimes with the adolescents, then we'll ask them would they prefer if their parent went outside for a while and they could speak themselves. That's really helpful. Some teenagers want that, some teenagers don't.
Sure, they do.
And then for the younger kids, you're not having, I was about to say you're not having this sit-down conversation, but I'm just thinking about a child in clinic the other day where we were having a lot of talking, and then it's really important to play. So then you're going to do some of your assessment through play as well, and particularly as a physio, we're really lucky as physios because we have the ability to do our assessment through having fun. So a lot of the movement stuff you're going to assess through games, through pretending to be penguins and cats and crawling on the floor, and you know, kids love that when they see the person who's very serious talking to them and then the next minute they're rolling on the floor.
I love it.
Pretending to be a snake or a lizard. So generally then at the end of the appointment you're going to explain what your service is, would they like to come back, what type of treatment would work for them in terms of where they're living, would they come for one-to-one in-person appointments, would they come for virtual appointments online, like using video conferencing, or would they come to our group program, which is a whole kind of 12-month program of about 15 families together for kids between 6 and 12, and then for the older age group, and that's fascinating how that works, and particularly for the kids who are, you know, socially maybe don't have friends or they just have less confidence. You might start with one-to-one treatment and then bring them to group because they want to go, and then it's just amazing to see them having fun and starting to have nicknames for each other and making friends and just laughing, and that's so beneficial. So then you have to, obviously in terms of research but also service delivery, think about, well, is any of this having an effect? So in the past we would have always thought about our outcome measure, which is like what are you measuring to see if change is happening? It would have always kind of in the past been BMI or adjusted for kids. So BMI centile or BMI standardized deviation score. But now, thankfully, the field is moving towards, okay, we need measures of growth, but we also need their fitness level, their quality of life. Are they going to school? Are they staying in school? Are they finishing school? Are they making
some of these
friends?
Kids not go to school because they don't feel that they can? Okay.
Yeah, so some of the kids, depending on what school they're in, depending on where they're living, they may, and particularly since COVID as well, so some kids are finding it hard physically to get to school, so it might be actually very difficult physically to get it to school, to sit in a desk that fits. Others, there may be just...
when you say physically get to school, it's not the distance of the school, it's actually...
No, the moving around. So for some of the kids with severe obesity, they might be in a lot of pain, they might have a lot of breathlessness, It can be difficult to move. So like you would think of any other child with any other disability, whether it's a neurological disability like cerebral palsy, or whether they might have had a head injury and they have problems since that, we have to make sure that we adapt things and modify them to let a child get to school. Some of the kids then will have, unfortunately, experience a lot of teasing and bullying, so the school environment isn't safe for them. It can be very hard to learn, as you can imagine, if you don't feel safe. Some of the kids, if they have different forms of obesity, might just be thinking about food all day long, so they can't concentrate. Those types of obesity are, thankfully, in terms of prevalence, much rarer, and we know more about them now. So it depends on the child, but school can be very difficult for some. Some schools are really brilliant at supporting kids, and the PE teachers are really good. They understand how to motivate and how to encourage children. Others really kind of think of it in terms of this child, why won't they just need to get going, they're lazy. And that's really hard for the child, because they know that they're being thought of like that. But things are moving, I would say, definitely in the right direction.
When we came in earlier, we were talking about food poverty and the fact that a lot of children that are living with obesity, they would live in areas of food poverty. You were talking about when you were in America having to take a tube, but there are food deserts here in Ireland as well, and we can't escape that. And
No.
I would often liken it to how much is a punnet of strawberries and how much is a bag of chips, and what's going to fill my child more if I am on the breadline and can't afford food.
Absolutely.
So, and then you were even saying sometimes there's no access to a kitchen or a cooker or even a kitchen table.
Yeah, or a fridge.
Or a fridge.
Yeah.
So when you're coming from a place of waggy finger, these kids are lazy and are overeating and all the rest, you really can't. You have to strip away all that.
You have to. Yeah. I think generally most people are probably just a bit conditioned anyway to thinking about things through their own lens, and often in healthcare where people who've been lucky enough to get access to third level education, and very often maybe, I think it's changing thankfully, but maybe haven't had deprivation in our lives. So it's very hard to understand what that means if you haven't experienced it. But we know in Ireland, so 1 in 5 children in primary school children would have overweight or obesity, and then in teenagers 1 in 4. So about 18,000 children, we estimate, have severe obesity, and then about 80,000 children have obesity, and then about 250,000 children have overweight and obesity. So we have a problem that we need to address, and that's where the prevention aspect is so important, and the built environment, the food environment, how we plan our communities, what planning laws are there, how we plan our schools, whether there's access to sheltered places to move, whether it's built into the school day for movement, what the food environment in the school is like. All of these things are really important. Access to breastfeeding, support for breastfeeding, really, really important. And how we wean children onto solids. All of this within the first 1,000 days is really important in terms of appetite development, preference for foods, how we are fed in terms of nurture, how we link food with love. All of these things are linked to how our preferences for taste of certain foods develop. So like during the last couple of months, there was a really interesting study in the UK. I don't know if you saw it around. They looked back at children who were born. So after and during the Second World War in the UK and Ireland, there was a sugar ration. So children born at this time weren't exposed to sugar through their mothers because their mother, there was limited sugar supply. And then there was other children who were born when the rationing was being lifted, so there was an increase, and then the ration was gone. So there's another kind of group of babies who were born then. This is in the 50s, between I think 1953, the sugar rationing lifted. So some researchers last year published work looking back at thousands of children in the UK that were born before the sugar rationing, during sugar rationing, and then after sugar rationing. They were able to look at the dose response for children who had no sugar while they were in utero, and then those when they were babies, and looked at the risk of heart disease, type 2 diabetes, hypertension, obesity. And they did find a really clear link in terms of if a baby in the womb is exposed to a lot of sugar, how that will affect their long-term health, and they were able to show dose response. So that means that in scientific terms, depending on how much sugar they were exposed to, they could show that there was a higher risk of illness. So this first 1,000 days is really important in terms of universal health care and prevention. So what mums are eating when they're pregnant, and their understanding of that on the growing baby is really important. And that, food preferences start from in utero. So when a baba comes out, being fed, whether it's breast milk or bottle milk, and then weaning at the right time and not exposing a child to free sugars, so added sugars at this time, is really, really important. Particularly, in that first year of life. So let's say 6 months, they're starting on their weaning onto solids. But before age 2, we have our really amazing healthy eating guidelines for 1 to 4 year olds in Ireland that are, probably some of the best designed ones in the world because they're very evidence-based. Professor Mary Flynn from FSAI headed up that, and it's an incredible piece of work. And what they find, and this study confirms as well, that children under 2 should not be having sugar. Now, you can say that nowadays, and it's like you're a bit of a lunatic saying that. It's like, how could you say that? That's ridiculous. But 20 years ago, that was just the norm. You did not have 7-month-old babies sucking lollipops. It just didn't happen.
Yeah. And even it's like everyone wants to give the baby a treat when they have the baby, which, it shouldn't. No. I remember having fights with people.
Yeah, and you do, and you're trying to talk to your grandparents, and they're like, didn't harm us, it didn't harm you. But we grew up in a completely different environment.
It wasn't as accessible. People didn't have as much money to spend.
It wasn't everywhere. And it wasn't different types of sugar as well. Because, on our website, on the RCSI Obesity YouTube channel, we have an amazing lecture from Professor Michael Goran, who's a Professor of Paediatrics from the States. And all of his work has been on sugars, and particularly now sweeteners, and the impact on the developing body. Because remember, we're talking about children who are developing, so it's really important for their liver that we really think about. It's not just it's no added sugar, that's okay. It's actually when you're putting sugar and sweet taste and bombarding the developing palate, you're then basically sidelining all the other tastes and taste buds. So even the bitter,
even artificial sugars need to
still
be
bombarding the child with sweet and preference.
I know you're under time pressure, and I need to get a couple of questions out to you because I want to.
I'm talking all around the house.
No, but I could do a Mick Crotty 2.5 hour with you, but I know that you're rushing to the airport, so I just want to ask. So first of all, someone wrote in to say, child has ADHD, they're on the stimulant medications which can inhibit appetite. So they don't eat really very much during the day, and then at night time they are starving. They want loads of food, they're eating copious amounts of it, and they're telling the mum, you're starving me, if the mum's trying to kind of hold off. The child is overweight. Is there a quick bit of advice that you could give there?
So you do need to think about what types of foods. So hydration is really important in terms of appetite. So having being hydrated is really important for particularly young children as well. Their body they're only developing the thirst mechanism, so often they'll interpret it as hunger, but it's thirst. So always making sure your child is hydrated is really important. You can check, are they hydrated, by looking at the colour of their wee. So urine colour charts for children are validated. If we have dark yellow, light brown, we need to drink more water. We want to be pale yellow in terms of urine. That's for all of us, but really important for little children and teenagers to know that when they go to the toilet, look at the colour of their own wee, and if it's on the dark side, drink. So hydration is really important in terms of this appetite control. Fibre also is really important. So many of our children aren't getting enough fibre, so they're not getting that feeling of fullness. And then if you're on a medicine,
can we just say what fibre, like what foods as fibre in. Now, I know my friend Aoife Harvey says 2 kiwis a day, I'll give you 10 grams of fibre. But you have to eat in the hairy skin, okay? But apart from that, so you know, your fruits and vegetables have a lot of fibre in them. I know there are cereals that are fortified that they say they're high in fibre, but they also can be high in sugar, so it's about watching those food labels too.
Yeah, looking at the food labels is really important. So you might even like if you look at something like bran flakes and you look at the different I nearly said hospitals, the different shops and their own brand versus big brands, you'll see a difference in fibre content and sugar content and salt content. So do know how to look at food labels. On Safe Food website, there's a really good education piece for food labels. But fibre you'll then get in your whole foods, so vegetables, but also in your brown foods, so brown bread, porridge,
your pulses,
your whole grains, your pulses, beans and nuts, and fruit, obviously, and vegetables. But for the little kids, I'll explain fibre is like a little brush. So it's like if you had a little brush on your insides, and fibre is like a little brush, and it brushes all your insides to help gather up all the poo. And then when you have enough fibre, you'll be able to have poos that are like sausages, and they're formed and they have a smooth surface. And that's how you know.
And they come out nice and
easily.
And
they come out nice and easily. There's no pain. But it's really important. I don't think fibre is talked about enough. No. But again, you can eat too much fibre. So it's depending on the age of the child. That's why having access to registered dietitians is so important, because you cannot transfer adult nutrition guidelines for children. It depends on their age, and that's why we have healthy eating guidelines for the different age groups.
So it was the medicines I asked you
yes,
about.
the medicines. So certain medicines as well for particularly for ADHD treatment, the longer acting ones will act longer, so it's easier in terms of taking them physically, but they'll have an impact on the appetite, that they will have no appetite during the day in the morning, and then they'll come home and they'll really be starving. So I mean, it's worthwhile discussing this with the person who prescribed them. There are other kind of non-obesogenic or less there are options that will have less of an impact.
There are shorter acting stimulant medications that won't curb the appetite as much for such a long period of time, and they will have those little spurts where they will find that they will be hungrier in the day, and they won't just be leaving everything till night time. So I think it's definitely worth discussing that.
But also as well, for some of those kids, like having, because often they're worried about when are they going to eat. So literally having a timetable written up that this is the times they're going to be eating at. That's really important for some of these kids, because they are really feeling like they're going to be starved or they're not getting enough food. So knowing that, oh yes, I'm going to be getting food here, I'm going to be getting food there, and in the meantime, if I'm hungry, that there are healthy snacks available. So that there are, vegetables, fruit available to snack on. Some people will roll their eyes when you say that, but this is just so important for child health. You have to have fruit and veg, and we have to expose them to it. So most children, often many of us won't like certain vegetables when we're growing up, but it's how we present them, how we cook them, and that we keep offering them multiple times.
So teenage girl putting on weight, she's very big boned, but she is carrying weight, loves eating, but is very down in the dumps about her body. Mm-hmm. What can mum and dad do with that? Okay,
so it's good that you love eating, first of all. That's a great thing. It's really important that we love our food. Puberty means that we go through this period of reduced insulin resistance. So how our body uses blood sugar and processes blood sugar. There's 2 times in our lives that our body shifts, and it's harder to process the sugar. During pregnancy, we get this natural reduced insulin sensitivity or insulin resistance, and then in puberty. So in puberty, girls will gain more fat tissue, and that's normal, that's typical. But the challenge is, so on the one hand, we want to be positive about eating, we want to enjoy eating, we need to make sure we're eating. Teenage girls have to eat. Too many teenagers are skipping meals because they're trying to restrict their eating. When we restrict or diet, our body just does everything it can to make sure that we eat, and it'll increase our appetite. So we need to eat our 3 healthy meals and 2 healthy snacks. Need to get enough hydration, so that girl makes sure that she's drinking enough, so 1.5 to 2 litres of water a day, depending on how active she is. And making sure she has a healthy breakfast, a lunch, a dinner. And when she says did you say that she mentioned overeating?
Yes, she's eating a lot of food.
Okay,
the mum feels she's overeating. The girl is unhappy, but she's still overeating.
So we have to understand, what do they mean by overeating? Because sometimes it's not that we're overeating. We're actually maybe not eating enough at all. It's just all the wrong stuff, or in the wrong proportions, or at the wrong times. So really kind of key things: 3 healthy meals, 2 healthy snacks. Try not to be eating after 8. Get enough sleep. So we know our sleep will really impact our appetite hormones. We tend to be hungrier if we're not sleeping, and we look for higher calorie foods when we're not sleeping enough. Drinking enough water, and then making sure there's adequate fibre. Look at the food pyramid. Look at our healthy eating guidelines. Often we're actually far away from that, and we just need to try and work out, okay, what bits do we need to eat? Make sure there's fibre in the diet, make sure there's enough protein, and then thinking about, well, how much of the food is ultra-processed food? So usually ultra-processed food will have high sugar, high salt, high fat, and then not very much fibre. So thinking about the types of foods, the portion sizes, and then the bit about not being upset about your body, that's a separate thing. It's really important for those kind of teenagers, I think, to not be on social media, to start thinking about their body as this amazing, an incredible, I was going to say organ, but it's so many organs, so it's this incredible thing.
It is an amazing
It is an amazing thing, and that it's strong, and it's, we want to build your fitness and your strength and your ability to feel positive in yourself. You shouldn't look like other people. But you should feel comfortable in what you're wearing. So making sure that you're, wearing a right-sized bra, really important, and something that most people don't even ask a teenage girl, have they had a bra fitted? And if you're in a bigger body, this is even more important, that it's comfortable. Wearing cotton underwear so that it's not chafing, not causing, like synthetic fibres will be more difficult. And then being able to, I suppose, learn to accept your body and learn to have it, be thinking about your goals in terms of not weight loss, but getting stronger, getting fitter, sleeping better, being at one with yourself, not thinking of your body as completely separate to the rest of you, that it's all you, and it's not a bad thing to be in a bigger body.
That's really important. But how do parents, if they're worried about their child's weight, I know it depends on the child's age, so for teenagers in particular, is it okay to bring the topic of weight up? How do they do that in a really sensitive way? No one wants to call their child fat. Yeah. That could have a negative effect on it, but how do they bring it up? Because if it's an elephant in the room, how do they bring it up?
Well, I think the focus has to be health. So let's, coming into January, our family, we need to get healthier. So it's not about this one person, it's all of us. We've been looking at our phones a lot. We've been on screens a lot. Our meal times are all over the place. We're not sticking to a regular pattern. We need all to be kind of just getting fitter and healthier and eating the best type of stuff that we can within our budget. So we're going to, let's say, have some idea about our health. So are any of us in the family, what's our height, what's our weight, are any of us breathless, are any of us feeling weak and tired, what can we do as a whole family? So not making the child feel separate to everybody else, even if their body is completely a different shape to everybody else. But also not making it a taboo that you can't talk about it, because sunlight is a very good disinfectant. So letting these conversations happen, but parents have to be very conscious about how they speak about their own bodies and how they speak about other bodies when they're watching television or programs or looking at their phones, not commenting on other people's bodies. No point saying, oh, but you're brilliant, you're beautiful, you're wonderful, and then the next minute they're like, did you see so-and-so? Or, oh my God, my bum's so big. These messages, mammies
all over Ireland, stop telling yourself and the people that you live with that your bum is too big or your belly's too big, because your little girls and little boys hear that.
I know. And they pick it up so early. They do.
And all the mammies in Ireland, you're all gorgeous, so you shouldn't be saying it.
No, exactly.
And it's so important because it does feed down to
it does.
Younger generations.
Absolutely. Like we've had 6-year-olds come in and say, I need a diet. And you can't have a 6-year-old child thinking they need a diet or even knowing what a diet is. So Yeah, learning to love your body, and often sometimes with some of the kids we're actually teaching them how to walk, to have posture, to feel good about themselves, to put their chest out, to not worry if their tummy's out. It's okay, and to just feel positive about themselves. But for that girl, maybe it's really important to link in with your GP, make sure your GP is trained, has access to the course online. When you're making the appointment with the GP, let them know that it's about this topic so that there's enough time that they can prepare themselves. If there's mental health concerns around body image or self-esteem, to link in with services like jigsaw.ie, or if needed, get a referral to primary care psychology. Yes, there will be long waits for all these primary care services, but you still have to get a referral in.
Okay.
Even if you're going to wait 2 years, which might be the case in some places. And then reach out and look for help. So, even contacting, I'll regret it, but even contacting our service, even by email, it's just having some contact with people that understand often is really important.
I'll put this all in the show notes. Unfortunately, we have to wrap it up. I'm definitely getting you back.
Okay, thank you very much.
But I do want to ask you my 2 burning questions.
Oh, yeah. Oh, God, yeah.
What advice would you give young people today?
I think to understand that everything's a phase. Things change. You're not less than anyone else. You're really, you've so much worth. Yes, you get a hard time from adults. They're a pain in the ass often. But, your lives now may be very different in the future. So have hope and give yourselves a break, laugh, have fun, and do try and maybe stay offline, because getting to know each other in the offline world, or even just smiling at other people your age, these are really important things.
And what's the meaning of life?
From a biological point of view, I think life is just to survive for all living things. But then from, I suppose, a human point of view, I think it's probably about for me, it's about connection, and no matter what people's experiences are, having that connection between two hearts and being able to have the most amazing experiences with people from all over the world or in very different situations, and connect through humour or through honest conversation or music or art or whatever it is. I think it's probably it's this kind of communication, the social connection that we have, I think, for humans is the meaning of what we're meant to do. But then it depends on, everyone derives their own meaning depending on what their experiences are, I suppose.
Grace, it's been an absolute pleasure.
Thanks, Laura. Thank you so much. Thanks.